Right. So today's topic is schizophrenia. Schizophrenia is a mental disorder which is characterized by some sort of symptoms which we will discuss. We will cover the topic like difference between neurosis and psychosis, definitions, epidemiology of schizophrenia, etiology, clinical features, diagnostic criteria, management, course and prognosis. There is a question which is frequently asked is what is the difference between neurosis and psychosis? So before coming to the main content, there is a common misconception regarding schizophrenia that it is a multiple personality disorder or split personality. So it is called as they are split from reality and cannot tell what is real and what is not. So this is a misconception. This is not a personality disorder or a split personality. The term schizophrenia was coined by Eugen Bleuler in 1908. So this split personality is the part of dissociative disorder, which is known as dissociative identity disorder. This is not schizophrenia or also known as multiple personality disorder, which is also a part of dissociative disorders. This is the different thing we will discuss only the schizophrenia right now. So what is the neurosis and psychosis? This is the question, what is neurosis and psychosis, and the question will also come as what is the difference between neurosis and psychosis. So traditionally, you all know that there is a classificatory system which is known as ICD-10, and nowadays ICD-11 is in the practice. So traditionally in ICD-9, there was a division between disorders in a broad category known as neurosis and psychosis. So, however, the term neurotic is still retained for the occasional use. For example, in ICD-10, F40 to F48 is designated as neurotic, stress-related, and somatoform disorder. So, neurotic word is there in the specific category in ICD-10. So, we do not classify broadly as in ICD-10 as a set of diagnoses is neurotic diagnosis and set of some diagnoses are psychotic diagnoses. So in ICD-10 further instead of neurotic psychotic dichotomy, the disorder are now arranged in the group according to major common theme and descriptive likeliness. So disorders in ICD-10 are classified for example as the chapter F and subchapter 30 to 39 is for mood disorders in which there is a bipolar disorder, mania and depressive disorder and recurrent depressive disorder. F60 to 69 is for disorder of adult personality and behavior. F10 to 19 is for substance abuse disorder like alcohol, opioids, cannabis, cocaine, tobacco are considered in F10 to F19. And F20 group is for psychotic disorders, F23 for acute and transient psychotic disorder, F20 is for schizophrenia. So its use does not involve assumptions about psychodynamic mechanisms, but simply indicate the presence of hallucination, delusions, or a limited number of severe abnormalities of behavior. So this classification IC10 is based on the presence of set of symptoms like hallucinations and delusions. So this is the chart uh, which depicts the difference between neurosis and psychosis. In neurosis, insight is present commonly. Commonly, insight is present and it is usually absent in psychosis. Judgment and reasoning is intact and judgment and reasoning is impaired in psychosis. Reality contact is present. The contact with the reality or immediate surrounding or immediate situation is contact, and this is lost in the psychosis. Delusions usually absent in neurosis and delusions usually present in psychosis. Hallucinations usually absent, hallucinations usually present. Change in the personality is usually absent, the change in personality is may be there in the psychosis. So you can see that the gist is the insight is absent in psychosis, judgment is impaired, reality contact is lost, delusions are present, hallucinations are present, and change in personality may be there. So this is psychosis, and if this is not, then neurosis. Now coming to the schizophrenia, the term is given by Eugen Bleuler. The word has been derived from Greek with schizo means split and phren meaning mind, splitting of mind. But the definition of ICD-10 says the schizophrenic disorders are characterized in general by fundamental and characteristic disorders of thinking, perception, and inappropriate or blunted affect. So as per ICD-10, three components are there: impairment in thinking, impairment in perception, and blunted or inappropriate affect. Affect is immediate expression of emotions, what you observe in the face of the patient. Thinking is thought process. Uh, perception is by the means of sense organ what you perceive. So ICD-10-11 is is more elaborative, more in the detailed. So I have break up this definition in 5 points, but it's a continuous definition. So this is the definition by ICD-11, which says schizophrenia and other psychotic disorders are characterized by significant impairments in reality testing. These are the uh, highlighted words which are used, and alteration in behavior manifest in positive symptoms such as persistent delusions, persistent hallucinations, disorganized thinking, and disorganized behavior. So the second word is positive symptoms, which encompasses delusions, hallucinations, disorganized thinking, and disorganized behavior. Further, and experience of passivity and control. Negative symptoms such as blunted affect. Experience of passivity phenomena and control phenomena, which means the someone has have a control on his behavior, or someone else is moving his body parts or controlling his thinking. This is called as passivity. And negative symptoms such as blunted or flat affect, and evolution and psychomotor disturbances. So this is the definition by the ICD-11. Now, epidemiology of schizophrenia. When you will be asked what is the epidemiology of schizophrenia, then you have to write the prevalence of schizophrenia is 0.6% in India. The lifetime prevalence of schizophrenia is nearly 1% in India. It affects all age groups, gender, and races. It is not restricted to any of the group. The common age of onset in male is 10 to 25 years, and in females it peaks at 25 years and 35 years of age. So in the females, it has bimodal pattern, which you can see in this graph. The red one has two peaks. There is This is the peak at 25 years, and this is the peak at 35 years of age. And in the male, the 25 years is the peak age of onset. The onset can be early onset or late onset, and it follows waxing and waning course. So this is about the epidemiology. Now coming to the etiology, we will discuss the biological etiology mainly. So many authorities suggest that it has multiple factors must cause schizophrenia. The one is biological factor. In biological theories, we have biochemical theories, we have genetical and perinatal theories, and neurostructural theories. In biochemical theories, there are two theories. One is dopamine hypothesis, and this hypothesis suggests that there is an excess of dopamine-dependent neuronal activity in the brain may cause schizophrenia. So, dopaminergic activity is increased in the case of schizophrenia in some tracts of the brain. Uh, this one is the main theory, and the other theories are the various other abnormalities in the neurotransmitters like norepinephrine, serotonin, and acetylcholine is also uh, claimed. In neurostructural theories, research suggests that prefrontal cortex may never fully develop in the brain of person with schizophrenia. So there are abnormalities prefrontal cortex, which is seen in the structural imaging of the brain like MRI, functional MRI, SPECT or others. In genetic factors, this disorder more commonly seen in the people born of consanguineous marriages, and it also shows that relatives of schizophrenics have much higher probability of developing schizophrenia, and this disorder is also seen uh, as much as 49 to 50% in twin studies. If one twin is having schizophrenia, the chances of having schizophrenia in other is almost 50%. Some perinatal risk factors are also implicated, like uh, maternal influenza, birth during late winters, complication of pregnancy, particular during the labor and delivery, are seen more in these cases. So this part is the history based. It is not always true, but uh, commonly seen with these disorders. Now coming to the clinical features, when you will be asked what are the clinical features of schizophrenia, so you have to write there are 5 sets of symptoms of schizophrenia. One is positive symptoms, then negative symptoms, cognitive symptoms, affective symptoms, and motor symptoms. These symptoms collectively, when present uh, in a person, you can say the person is suffering from schizophrenia. In positive symptoms, there are delusions and hallucinations. In negative symptoms, apathy, anhedonia, abulia, or avolition is there. So you can understand simply by positive and negative is that if a person have a is all right and does not develop schizophrenia and has certain kind of traits and behavior, you know. So when something which is not there in the behavior of the patient, like delusions and hallucinations, delusions and hallucinations come up in his personality, so this is called as positive. And apathy, anhedonia, abulia, the person what was doing is not doing now. He's not interacting with the person. He is remaining to self. He's not concerned with his immediate environment. He's not going to work. There is a occupational impairment. There is a personal hygiene impairment. So the things which has gone from his personality traits is considered as negative symptoms. The next one is affective symptoms. The affect may be inappropriate, incongruent to the thought, constricted affect, or restricted affect. Cognitive symptoms encompasses concentration, inattention, impairment in memory, impairment in executive functions, and reduced processing speed. The motor symptoms are catatonia. Okay. So this is the chart. If you will make this chart in your answer sheet, you will get good and handsome marks. So we are now going to the detail of these symptoms. So delusions by definitions is a false belief which is based on incorrect inference about external reality. So inference is incorrect of these patients about what is happening around them, which is not consistent with patient's intelligence. The thing which he is saying or believing is not consistent with the intelligence of the person, and nor it is prevalent in the cultural background. And this false belief cannot be corrected by reasoning. This is a complete and standard definition of delusions. And on the basis of content of delusion, the delusions can be type of persecutory if the person is feeling that someone is plotting against him. The plotting against him is the content of the delusion, and this plotting against him is false belief, which is according to the definition of delusion. The person can have referential kind of thinking, grandiose ideas, delusion of guilt, nihilistic delusions, religious delusions, hypochondriac delusions, jealous delusions, delusion of control, and thought insertion, withdrawal, broadcasting. So these type of delusions are present in the case of psychosis when delusions are there. And these delusions are not pathognomic of schizophrenia, may found in other disorders also, like depression and OCD and mania. In mania, basically you will find religious kind of delusions, grandiose kind of delusions, no, nihilistic kind of delusions you will find in the depression. The delusion which are pathognomic or more is found in uh, schizophrenia are persecutory delusions, referential ideas, thought insertion, delusion of control, withdrawal, broadcasting. Thought insertion means someone has plotted some kind of thought in his mind and he believe that these thoughts are not mine. In thought withdrawal, the thought of the person is withdrawn by some force or agency, and the brain is somewhat empty because of this. Broadcasting means the thought of the patient is broadcasted by other agencies like social media, TV, radio. Uh, he will express that person will get to know my thoughts because these are being broadcasted upon radio or TV. So these kind of delusions patient may have. Similarly, delusional mood, delusional perception, delusional memory, or delusions related to sex may you find in these patients. So basically, delusions are false belief by definition. It cannot be corrected by reasoning, and it is not in conjunction with the intelligence of the person and cultural background. Now coming to the hallucinations. Hallucinations by definition is perception without external stimuli. There is no external stimuli, there is no external object, but the person is perceiving those that the thing is actually there. And you all know that there are five sense of organ, uh, like ears, skin, eyes, nose, and tongue. So we have five sense organ. Then abnormality in these five area you will find as hallucinations. If it is in the area of auditory audition, then this will be auditory hallucinations. Then tactile hallucinations, visual hallucinations, olfactory hallucinations, and gustatory hallucinations. The basic idea is the external object is not there, but the person is perceiving this. There is no source of voice. The person is perceiving the voices. There is nothing in the skin, but he is perceiving as the bugs are crawling on his skin. There is no object or visual object is present in the environment, but the person is perceiving that I am able to see that this is there, but no other family member or other informant is able to see that. Similarly, olfactory hallucinations and gustatory hallucinations. Now coming to the negative symptoms. Negative symptoms, there are 5 A's in negative symptoms. First is affect, elogia, ebulia, evolution, and inattention. So affect is usually restricted or flattened affect. You will find that minimal or no facial expression the person is showing while you are interviewing this kind of patient. You won't find any kind of emotional uh, expressions. In elogia, there is reduced speech. In ebulia, decreased lack of will or initiative. Evolution is apathy and inattention. Patient may be inattentive to the environment. So these are the 5 A's of negative symptoms. Okay, we have covered positive symptoms and negative symptoms. Now motor symptoms. Motor symptoms, there is a term called as catatonia, which encompasses various sign and symptoms like excitement, posturing, flexibility. These are the key words for schizophrenia, in which excitement is agitated, purposeless motor activity and uninfluenced by external stimuli. Okay. There is no role of external environment in excitement of catatonic patient. The excitement will be unprovoked. Posturing, the voluntary assumption of an inappropriate or bizarre posture, generally maintained for long periods, maybe hours or minutes. Flexibility is a condition in which a person can mold it into a position that is then maintained. In waxy flexibility, what happens when you mold a person in such a in an awkward position? You will find that you are molding a wax. So the term came from the wax. It is waxy flexibility, and when you mold the person in an awkward position, the person will hold that position for a long time. So this is waxy flexibility. Others are negativism. Negative symptoms shouldn't be confused with negativism. This is the another phenomena. In negativism, there is motiveless resistance to all attempt to be moved or to all instructions. If you want to move the person forward or backward, or you want to let him sit on the chair, let him lie down on the bed or couch, the person will show some kind of resistance. And if you are not physically moving, or you are giving verbal instruction that you should sit on the chair, the person will also resist that instruction. Mutism is voicelessness without structural abnormalities. There is no structural abnormalities in the brain like you find in hemiplegia or hemiparesis. There is a loss of voice. So voicelessness in this catatonia is not by the structural abnormalities. Stupor, markedly slowed motor activity, often to the point of immobility and seeming unaware of the surrounding. But the patient is not unconscious. The motor activity is so much slowed, and he is so much immobile and seeming unaware to the surrounding is the stuporous condition in catatonia, and which is not due to the secondary to the physical problem. Now, disorganized thinking and speech, it has incoherence, irrelevance, neologism. Incoherence means thought production with no logical or have no grammatical connections. The person, when you are interviewing the patient, you will find his speech has no logical connections, and it is also not grammatically correct. Irrelevance is when you ask the answer that is not in the harmony with the question asked. You are asking something and patient is answering something else. Neologism is creation of new word. The person will create a new word for which he has some special meaning, and it is not found in the standardized dictionary or not uh, prevalent in the socio-cultural environment also. Some words are found in some sort of certain societies and community, but uh, neologism does not fulfill that criteria also. Other features are violence, aimless wandering. You will find in the history the person used to wander aimlessly. Patient may become violent. Poor personal hygiene is there. Inappropriate clothing according to the weather. You will find that in the summers the person is having heavy clothes on him or winter clothes, and vice versa. Impulsivity is there. The person may have suicidal and homicidal tendencies. Now, this is the diagnostic criteria, ICD-10 criteria of schizophrenia. We are not currently discussing ICD-11 criteria, okay? So, because it is recently launched, so you can write ICD-10 criteria. So, like these are the major four symptoms, A, B, C, D. There are 8 symptoms, set of symptoms, but these symptoms are major symptoms. Should be present in the person at least for the last 1 month. Okay. You can remember these highlighted words to write the diagnostic criteria. If you are not remembering the whole criteria, you can just write these clicking words. Like for in criteria A, there is thought echo, thought insertion or withdrawal, and thought broadcasting. Insertion, withdrawal, broadcasting, you know, and the thought echo is when the person is listening to his voice himself. What he has in his mind, he is listening those thought process as if it is present in the external environment. So this is fulfilling the criteria of hallucinations. Delusion of control, influence, or passivity. Clearly refer to body or limb movement or specific thought, action, or sensations, and delusional perception. So you can simply write delusion of control, influence, or passivity. The C is hallucinatory voices giving a running commentary. Okay, the voices are common, which is uh, have a content of running commentary on the patient's behavior or discussing the patient among themselves. You know, two or more voices discussing the patient among themselves or other type of hallucinatory voices from some part of body. You know. This is also the thing. If the voices are coming from the body part, like from his fingers or hands, this should also be considered as hallucination, and the body part is considered as external uh, source of external voices. Persistent delusion of other kind may be present, which are culturally inappropriate. And for example, the superhuman powers and abilities, like being able to control weather or being in communication with aliens from another world, these are the bizarre delusions. Bizarre delusions means which are uh, not in the control of power of any person. Yeah. The thing which cannot be done, 100% cannot be done by a person's power. These are bizarre delusions. And these are the other five criteria. You have to learn up to H criteria. I is for simple schizophrenia. Uh, you, if you want to write, you can write, but first four you should remember. In E criteria, persistent hallucinations in any modality. हाँ, किसी भी मोडेलिटी में हो सकता है गस्टेटरी olfactory visual auditory and which is accompanied either by fleeting or half formed delusion without clear affective content or by persistent overvalued ideas when occurring every day for weeks or months. These are the minor criteria. You won't find uh, very much in these kind of persons. Break and interpolation in train of thought resulting in incoherence or irrelevant speech or neologism. So you all know about incoherence, irrelevant speech and neologism. Catatonic behavior, you all know. Negative symptoms, you all know. The 5 A's, apathy, paucity of speech, affective blunting, inappropriate affect, evolution, abulia. So negative symptoms are the minor criteria. So in first major out of four major criteria, if one is present for the last 1 month, you can diagnose the case as schizophrenia. And in the minor criteria, if you have two, at least two for the last 1 month, then also you can diagnose schizophrenia in the person. Okay, this is the diagnostic criteria. Okay. So what is the management? As I have told, management has two parts. One is investigation and another is treatment. No, investigation. If you have asked about the treatment only, what is the treatment of schizophrenia? You have to write this only. If management is asked, you have to write all the things. So there are three components in treatment. One is pharmacological treatment, another is non-pharmacological, and the combination of the treatment. So in investigations, after you have done the examination, you have taken the history, you have done the neurological examination, you have done the mental state examination, a lab evaluation is required, and commonly it is routine investigation, otherwise it's specified. In routine investigations, you should go for complete blood count, electrolytes, fasting glucose, lipid profile, liver function test, renal function test, and thyroid function test. If this is specific in a female and you are suspecting, you can go for a pregnancy test and HIV test in certain situations. And for ECG, if you are suspecting cardiovascular comorbid illness or you are suspecting the drug will cause the cardiovascular side effects like QTC prolongation and ST segment elevation. In such a manner, you can investigate the patient. Now coming to the treatment, Treatment may be managed in indoor setup or outdoor setup. If it is required, uh, hospitalization, the indications may be posing danger to others, like if the patient is excited and violent or hostile, if he is posing danger to others or to the self in the form of suicidality. If the patient is having suicidal ideations, you should hospitalize the patient. Severe symptomatology. If the person cannot be managed at home because of the severe symptomatology, because of the holistic approach is required in terms of multi-specialty approach. So one should consider the hospitalization. If diagnostic evaluation is required in OPD, if you are not able to approach to a diagnosis or making a proper diagnosis, you can hospitalize the patient. If the person has complicated comorbidities, in that case also you should hospitalize the patient and on request of the family member of the patient. This is also the indication for hospitalization. The request of the family members cannot be denied. So the general principles are, you have to consider some points in drug selection, the efficacy of drugs, the adverse effect of drugs, the patient variables, and the point is no drug is universally effective. You have to make decision on the case to case basis, and you have to arrive at your judgment by considering all the points. Uh, And initial assessment should also elicit information about coexisting medical disorder. If a person comes with schizophrenia and comorbid diabetes, you should also give attention to the diabetes, not only to the schizophrenia. So few drugs are available with the like antipsychotics. In antipsychotics, we have first generation, second generation antipsychotics. At least you should remember three drugs which are commonly used in psychiatric setups is haloperidol, olanzapine, and risperidone. Haloperidol have a dose range of 5 to 20 milligram per day. Olanzapine has 10 to 20 milligram per day. Risperidone has 4 to 6 milligrams per day. The haloperidol is first generation antipsychotics, and the rest two are second generation. In another modalities of biological therapies, there is electroconvulsive therapy is available, and it is preferred when the person is suicidal, have highly aggressive behavior, have symptoms of catatonia. Catatonia is easily resolved by the treatment of ECT. It is preferred in catatonic schizophrenia. And for add-on treatment, if the drugs are not working well, so you can consider ECT as a add-on treatment uh, for a shorter period of time. This is about the drugs, and other modalities which are non-pharmacological available are psychosocial treatment, in which there is behavior therapy, group therapy, family therapy, social skill training. The person is having negative symptoms, the social skill training can be applied. Psychoeducation of the illness to the family regarding the nature of illness, course and prognosis, and how much the person will be able to perform, what will be the deficits. Vocational training is also there, occupational therapy, motivational therapy to the patient, and token economy for the negative symptoms. These are certain non-pharmacological treatment which you can apply on the case-to-case basis when these are required. If there is some problem in the family, like expressed emotions are more in the family, you can go for a family therapy. Uh, Expressed emotions means the comments and behavior of the family members are critical to the patient, which may add upon to the disorder to be deteriorated. Okay, so about course and prognosis, the good prognostic factors are late onset of illness, when the person has achieved uh, ample about the personality traits and his functioning is achieved more than the late onset of schizophrenia is having good prognosis. Precipitating factor is there, and if you eliminate the precipitating factor, the prognosis is good. Acute onset have good prognosis. Good premorbid functioning. If the person are well adjusted to the previous environment before the illness, then there is good prognosis. And if the person is having concomitant more mood disorder symptoms, then also the prognosis is good. Family history of mood disorder, the prognosis is good. If the person is having good support system in the family, then the prognosis is good. If the person is having positive symptoms, then also prognosis is good, because the positive symptoms are easily controlled by the antipsychotics rather than the negative symptoms. Negative symptoms are difficult to treat, and sometimes it remains there, and may be found helpful with the psychotherapies and other therapies, which is non-pharmacological. So this is all about the schizophrenia. You should know at your level. Yeah. Now, thank you.